Hello everyone. Our today's topic is delayed NTD administration. This topic is important and it can be topic of transfusion viva and FRCPath part 2, and it can be essay question in part 1, and it can be a transfusion paper question in FRCPath part 2 as well. It can come in different forms. You can have a patient who has a potential sensitizing event and NTD administration is delayed because of any reason not given within 72 hours. So you can be asked to investigate this incident and what are the risks to the patient and how will you consult the patient about that and what will you say or explain to the patient. Secondly, it can be in the form of routine NTD prophylaxis. The patient needs NTD prophylaxis at 28 weeks, but because of some reason, the prophylaxis was delayed. You can be asked to investigate that why it happened, what are the implications of this delayed NTD prophylaxis to the female and to the pregnancy, and answer any question that the patient has. A third form can be a delayed NTD administration after childbirth. Because of any reason, uh, uh, NTD administration has not been done within 72 hours, and you receive a result of Glyhover test from the lab, and it shows a very high amount of FMH. Then you can be asked what are the implications of these results on the patient, future pregnancies, and what are the implications and risk at the moment. So we have a case. Uh, According to this case, there is a 32-year-old female delivered a healthy baby on a Friday evening via normal vaginal delivery at a local hospital. She is blood group O Rhd negative and the baby is O Rhd positive. She was sent home same day after taking samples for Glyhover testing. Glyhover test shows fetal maternal hemorrhage of 40 ml. Due to long weekend, she was called on Tuesday after a long weekend regarding the results and asked to attend hospital for NTD induction. You have been contacted by a transfusion practitioner regarding this patient. How would you manage this situation as a consultant hematologist? So this is a significant event. You need to do a detox about this case, and you need to nominate a person from the transfusion practitioners to investigate this case, why there is a delay in NTD administration. The important thing is the duty of candor and the patient worries, because the patient would ask now, but what are the implications of this delayed NTD? Am I sensitized because of this? What are the risks to my future pregnancies? Whether my baby can be affected by this NTD or not? You need to explain everything to the patient, risk of NTD immunization to the patient. Uh, I should add here immunization of the patient, risk of further antibodies formation, because if you have one allo antibody, you can have another antibody formation as well, allo antibody. And these antibodies If they are from RH group, they are significant enough to cause hemolytic disease or fetus or newborn and can lead to dire consequences. So you need to explain all the points to the patient, and uh, you need to investigate the circumstances which led to delayed NTD administration on this patient, and you need to update the patient about all these investigations. Appointment should be arranged for this patient to check the antibody screen to see if this patient has developed uh, NTD or not. After the conversation, you need to give the patient all the information related to NTD immunization, hemolytic disease of newborn, and if the NTD is confirmed, you need to give her an antibody card as well, and you need to update the records of the patient. If the patient has any questions, you have to answer that and discuss this case in the regular hospital meetings which discuss the patient and transfusion lab and incident meeting in your hospital. So gather information from the clinical team, from the lab, and from the patient itself. Find out uh, why the patient was sent home without administering NTD on the day of discharge. Whether it was a clinical team decision to send the patient home or it was a patient request to send her home. Before going home, whether the patient has enough information that she may require NTD after birth, whether she had any idea about fetal maternal hemorrhage test post-delivery or not, whether the discharging team members were a junior team or there any senior person, registrar or consultant present on that day or not, whether they were contacted uh, that they are sending this patient home or the patient is requesting to go home today, or before sending the patient home, whether the team, discharging team, has made any arrangement to follow this Klein-Howard test result, because there was a long weekend coming up, and the ship would be handled by the on-call team, a single person, whether he was aware or she was aware that um, FMH test result call is expected from the lab, and we need to act on that if it is indicated. Then, from a blood bank side, when the FMH test was done and it is specified that there is 40 ml of fetal maternal hemorrhage, did the blood bank inform the on-call registrar or obstetrics or not? And if yes, whether the obstetric registrar took any action on that or not. If the blood bank did not update the obstetric registrar on call, it means there is a staff who is not aware of the uh, SOPs related to FMH testing, whether the staff was competent enough, whether the blood bank staff was a junior, whether the blood bank staff was aware of the hospital SOPs or not. So collect all this information from the patient, from the blood bank, and from the clinical team. Organize the information and arrange all the data collected and present it in the hospital transfusion team meeting. This process was previously called as root cause analysis, but now there is a new term called PSIRF, Patient Safety Incident Response Framework. Analyze the data and find out where is uh, where is the problem, who had made the mistake. So allocate a cause to this incident, and after finding out the cause, update the patient about the investigation's result. Now the next step is corrective and preventive actions. If the cause has been identified and it is either a clinical staff or a blood bank staff or um, someone else, take their feedback about this incident, check the competency of the clinical or non-clinical staff, check whether he or she is aware of FMH tests, SOPs, and its implications on the patient, and book a follow-up test for the patient as we have discussed earlier to see if the patient has developed any NTD, NTD or not. If yes, then we need to give antibody card and we need to update the patient record. This case is short reportable and we need to report to NHS England and improvement as well. If the problem is in the hospital uh, standard operating procedures or SOPs regarding FNX results, they may be old and there can be a problem in SOPs as well. Make sure they are updated to avoid such incidents next time. Make sure the SOPs are followed by the clinical staff and by the blood bank staff. The blood bank staff competencies or the clinical staff competencies, they are updated and up to date. Check how many such incidents has happened in the last year. Take a data of such incident and arrange some actions which are smart, actionable, and fruitful. And after those actions, re-audit the similar cases to see if they have made any changes in your hospital setting or not, and present the data locally or regionally to see your hospital progress and to show your hospital progress. So delayed NTD administrations um, has a lot of implications to the patient, to the future pregnancy or fetus. NTD must be prophylactically given between 28 to 30 weeks of pregnancy and within 72 hours of potential sensitizing event or on delivery of RHD positive baby. If there is a delay in administration of NTD on any of the above cases, this need to be reported, text, and discussed in the hospital transfusion team, and this is short reporting. This event must be fully documented by the staff involved. Consultant looking after this patient or responsible for the patient should be fully updated. NTD may still be beneficial if given a lot. The efficacy of NTD remains for 10 days almost. So it should be given up to 10 days if possible. Whenever there is a case of delayed NTD administration, there should be a full investigation and a report should be made. And make sure there is a meeting where a lesson learned from this incident is discussed And some preventive actions are taken to prevent such incidents in the future as well. If NTD is missed at 28 to 30 weeks, the prophylactic NTD should be considered after delivery, but the guideline says it should be given between 28 to 30 weeks. So if there is any delay, that should be investigated. If NTD is missed after potential sensitizing event, it can be administered up to 10 days, but the ideal period is within 72 hours. If there is any delay in this NTD administration, it should be investigated why such delay has happened. Because if you delay the NTD administration, you are risking the patient for immunization. And once there is one antibody formation, the patient is at risk of multiple antibody formation. And any antibody in the patient means a delay in provision of correct blood if required. The named consultant should be notified of any patient with missed or late administration of NTD, and this should be documented. And follow-up serology testing must be undertaken to make sure whether the patient has developed any uh, antibody or not. Why there is a term used 72 hours? The usual response time to procedure to produce a new blood group antibody following exposure to a foreign antigen is 72 hours. So intervening before then offers the best possible chance of avoiding death sensitization occurring. Anti-desensitization is dangerous. A woman who is anti-D negative is likely to make antibodies to D antigen if exposed in pregnancy or by blood transfusion. Once sensitized, this can never be undone. An anti-D can cause severe harm and death to a D positive fetus by causing hemolytic disease of newborn. Prevention of hemolytic disease of newborn. Identify the negative woman, check for immune anti-D. Give right blood components to the D negative woman. Counsel about sensitizing events in pregnancy. Give right dose of anti-D immunoglobulin at the time. All these points can help in prevention of hemolytic disease of newborn. What if there is no surety whether this anti-D is immune anti-D or this is non-immune anti-D? If there is no surety about that, give anti-D until you are confirmed that this is immune anti-D. Patient with immune anti-D should not receive anti-D immunoglobulin. If the woman has not had her D status confirmed one way or the other, give anti-D immunoglobulin until confirmed. So what are the causes that lead to delayed anti-D administration? It can be a sub-question in the FRCPath scenario. So you should remember or enumerate few causes to get marks. So the common causes are lack of education. Maybe there is a junior staff who don't know about the significance of FMH and may ignore it, and this can lead to anti-desensitization. Maybe there is a junior midwife or a junior nurse uh, who is on new to FMH testing results and not aware of its significance, it can lead to self-harm. Similarly, laboratory staff, if they are new in the training, newly hired, not aware of the SOPs or implication of fetal hemorrhage, it can lead to similar consequences, which is anti-D aluminization. Again, medical staff, lack of knowledge and lack of communication, uh, main issues. Assumptions, I mean, uh, the delivery is without any complication, and do not assume that there will be no uterine hemorrhage. This can be dangerous for the patients and the coming pregnancy. And lack of communication between the lab staff and and between the lab staff and the clinical staff can lead to such consequences of anti-D anonymization. So there should be a checklist which should be completed and signed by a senior staff uh, before sending a patient home to avoid this complication of anti-D anonymization and to reduce the risk of hemolytic disease of newborn. So these were the few points about delayed NTB administration. You can get this scenario as a clinical scenario in the FRCPath exam, both for part 1 and part 2. And you can get this case as a managerial scenario where you will be asked uh, uh, to investigate the case and how would you act as a consultant hematologist if you are appearing in part 2 FRCPath exam. So I mentioned different scenarios in the beginning. The delayed NTD can be uh, in a setting of potential cystosing event, can be in a setting of routine prophylaxis, and after uh, delivery of a baby. The FRCPath scenarios are usually in a small sub-questions type. They will give a scenario like that, and then they will ask you um, uh, what are the risks of NTD aluminization? What are the causes of NTD delayed administrations? What are the implications of delayed NTD? What advice you would give to such patient? So this question can be asked in multiple question forms and in different styles. So have a good goal regarding NTD and its consequences for the patient if it is administered delayed in different settings. In the end, I would say thank you and would request you guys to subscribe to Mothermore channel on the YouTube. This would give us some support and encouragement for the to the hematology level